illnesses are not sort of strange enemies that somehow invade us. They're actually manifestations of our life.
Honored author, world-renowned trauma expert, and as well as a specialist in childhood development, Dr. Gabor Maté. How do you think the languaging of what we are doing in healthcare has altered its very nature?
Just how you approach the patient, how you show up as a human being, makes such a huge difference to their experience. If I live my life differently, it's entirely possible that the process will then also alter, which is actually the case in many, many, many cases. My mantra is not why the addiction, but why the pain.
All right, we have another exciting episode of the Alchemy of Politics. I'm your host, Dr. Roushabodi, and season 2 is the Alchemy of Health and Healing. And if there's any guest that has not only embodied the spirit and the mission of what we're trying to do with this show, which is bring a new message of how to connect and heal each other, it's our current guest. Honored author, world-renowned trauma expert, and as well as a specialist in childhood development, Dr. Gabor Maté. Thank you for joining the show today.
My pleasure to be with you. Thank you.
I first came across your work actually when I was a pre-medical student in college, and the idea of this sort of biopsychosocial model was fascinating to me, and I was truly shocked that this was a sort of common knowledge, and I was thoroughly impressed. In your current book, The Myth of Normal, is really a tour de force on characterizing the entire way our society is really structured and how it misunderstands trauma. I would like to start with language. This book is not only amazingly well written, but it is particularly wordy in the best sense of that. And there's a lot of interesting terms that are used. The languaging of healthcare and healing right now, I think, has broken down, especially in this COVID era, into one of two things. There is a war metaphor, and I think we both know that that's been part and parcel of medicine for a while. The war on cancer, the war on this, and Sontag has elaborately described some of the problems with that. And now with COVID, we have frontline workers that are being deployed, and then they return back from their deployment, this sort of soldier barracks type mentality. And then, Michael Sandel at Harvard University has talked about how the lexicon of the market, which is certainly in your book in the sort of the latter half, has overtaken really all elements of society. We are not doctors, we are healthcare providers. Those are not patients, they're consumers. We have encounters with them. So I was just curious, to start off this interview, how do you think the languaging of what we are doing in healthcare has altered its very nature, its essence? I mean, a lot of your book is about misunderstanding core truths that lead to a lot of the painful outcomes that patients and we all deal with. So I was curious for your thoughts on that.
Well, as a former English teacher, I did that for 3 years and then decided that was way too stressful, so I went into medicine instead, But as a former English teacher and student, I do pay a lot of attention to language. Now, a few things pop up for me as you ask your question. One is that when I was still in practice and I was the director of the palliative care unit at Vancouver Hospital, looking after terminally ill people, I was asked to fill out a form. This is in the early 90s about an evaluation of a fellow physician. And they wanted to do things like how this person interacts with stakeholders. And I wrote a letter saying, there are no stakeholders here. This is not a mine. This is not a commercial enterprise. It's a hospital. So for me, stakeholders, it's kind of a commercialized, corporatized way to depict the participants in healthcare. So, and this has been happening increasingly, the corporatization of medical language. Number one. Number two, you talk about the battle that people wage, that so and so succumbed after a brave battle with cancer or ALS or whatever. There's a war assumption there. Like our metaphors are not accidental. And as I point out in the Myth of Normal, illnesses are not sort of strange enemies that somehow invade us. They're actually manifestations of our life. And insofar as we battle against the disease, we're battling against some aspect of our life that we haven't really understood. We can talk about this more, but I see what we call disease as much more of a process that's an outcome of a person's life trajectory. And it's not something to battle against, it's something to be understood and worked with. Now, that doesn't mean that we don't want to cure people or we don't want to help people with their distressing medical conditions, but it's the language and the mindset. It's not a battle, actually. It's how do you work with something. And finally, even the language of having a disease, there's a certain assumption. So if I say I have ADHD, by the way, with which I was diagnosed in my 50s, or if I say I have cancer, or I have multiple sclerosis, or I have depression, there's an assumption in that language. The assumption is there's an entity called cancer, there's an entity called multiple sclerosis, and there's an entity called me. And this entity has that entity. Like, I have a cell phone. Here's my cell phone. It's not a part of me. It's not a manifestation of me. It's just something that exists quite separate from me. I can put it down, pick it up, play with it, use it, but it's not me. To say that I have multiple sclerosis is to assume, which is what the medical ideology does assume, that there is this thing called entity called multiple sclerosis, which is an independent existence separate from me and a trajectory that's determined purely by its own characteristics and not with how I live my life. But what if I said that multiple sclerosis is not a thing that you have with a predetermined trajectory, but it's a manifestation of my life? It's a process. It's a process that, according to a lot of research, goes back as early as childhood in terms of the traumas and stresses that we take on and we then live through. Then it's no longer something that I have, but it's a process that manifests my life. That means if I live my life differently, it's entirely possible that the process will then also alter, which is actually the case in many, many, many cases. So even the language of having a disease, there's a kind of an assumption in it.
Well, let's follow up on that because in my field of gastroenterology and liver disease, I see plenty of alcohol abuse disorders and hepatitis C and other matters, functional bowel issues that have a lot of roots in early childhood adverse events. I try and I struggle to explain the difference between creation and choice. And it seems like this concept here that you're referencing, I think there's a key distinction there. I think no patient would willingly ever say we would never blame them for their disease, and you go at length to mention that in the book. At the same time, is there an implication here that through unhealed traumas, this is not an act of choice? This is not something they autonomously have chosen, but this is an act of creation in their part. Is that accurate?
Well, it's creation that's totally unconscious. The person doesn't know it, doesn't choose it, doesn't do it deliberately. But let's take a simple fact. An article in the New York Times just a couple of weeks ago about the risk of death or on childbirth of black men, black women and black infants. Did they choose to have a higher risk, or is that a function of multiple factors in a society that still racializes people? In Canada, my own country, indigenous people used to have no autoimmune disease whatsoever prior to colonization. Today, an indigenous woman's risk of rheumatoid arthritis is 6 times greater than average. 6 times. Now, did they choose that? Actually, when you look at the literature on multiple sclerosis, and this is what is so frustrating sometimes, is that you look at the scientific literature and it's completely opaque to most neurologists. But say multiple sclerosis or rheumatoid arthritis, in this case, rheumatologists, lots of evidence linking it to childhood trauma and lifelong stress, and linking the flare-ups to stressful events. Now, how do we treat both multiple sclerosis and rheumatoid arthritis? In fact, the whole range of medical conditions. We treat them with steroids. What are steroids? They're stress hormones. Shouldn't we ask ourselves that maybe stress has something to do with the onset of this condition? Now, if you look at the stresses that indigenous women in Canada are under, legacies of racism 100 years of sexual, physical, emotional abuse in residential schools, multi-generational addictions, violence, against sexual abuse of children, all imposed as a sequel of colonialism and residential schools and all that. But that means that how these people live their lives manifests in this rheumatoid arthritis. Did they choose that? Nobody chooses it. So when we point to the role of trauma and life in the instigation, or at least the rising of the risk for disease, we're not blaming anybody, but we are offering them some power. Because if they come to understand that how I live my life and how I relate to myself emotionally, my relationships, the stresses that I generate for myself unwittingly, they may contribute to the flare-up of my condition. Now you're giving them something to work with. So on the one hand, there's no blame, but there's definitely the offer of responsibility in the best sense of the word, meaning the ability to respond. And so otherwise, they're just at the behest of this unknown, idiopathic, mysterious biological condition that who knows why it came along. Again, I'm talking here about the science. Like there's so much research pointing out the not just the connection between childhood trauma, stress, and the onset of these conditions, but even the biology of it, how it actually affects the body.
Well, I guess this is what I find sort of so troubling is, to go back to the languaging of it. Like in the United States, the VA, the Veterans Healthcare System, for people who have served, for all its weaknesses, has come to a sort of Jesus moment about the tremendous impact wars had on the mental well-being of servicemen and women. And they have really made a concerted effort to transform their whole sort of biopsychosocial model of care beyond just traditional pills. That hasn't happened in our industry of healthcare. We now have a similar phenomenon of worker burnout, suicide, addiction.
Yeah.
Why? And you just pointed out that many neurologists and rheumatologists are unfamiliar with some of the hard science behind why trauma can lead to disease as a process.
Yes.
It seems like is this affected ignorance? Is this truly just a paradigm shift that needs to occur? Why hasn't this realization that has happened in adjacent fields not occurred within our own ranks?
Well, it's really a strange situation because the awareness that emotions and physiology are inseparable, that George Engel, who in 1977 proposed the biopsychosocial model, was not even a pioneer. I mean, he was pioneering in the context he was working in, but historically speaking, the mind-body unity and the awareness of the impact of emotions on physiology and vice versa has been studied and noticed for ever. In 1870 or so, when Jean-Martin Charcot first described multiple sclerosis, he said that this was a stress-driven disease. William Osler at Johns Hopkins said the same thing about rheumatoid arthritis. James Paget, a British surgeon, Paget's disease, in 1870, said the same thing about breast cancer. And fascinatingly, in 1939, there was a lecture given at Harvard University Medical School by a Hungarian-born American physician called Soma Weiss.
Mm-hmm.
And this article was actually, or his lecture, was actually reprinted in the Journal of the American Medical Association in 1940. And I'm quoting from my book, The Myth of Normal here. And Weiss said, social and psychic factors play a role in every disease, but in many conditions, they represent dominant influences. And then he added that mental factors represent as an active force in the treatment of patients as chemical and physical agents. This article was published in JAMA in 1940. To this day at Harvard, there's a research day held in Soma Weiss's honor, named after him. And yet, no more than 4 years ago, a prominent Harvard psychiatrist and author told me that to talk about mind-body medicine at Harvard is to jeopardize your career.
Yeah.
I mean, it's unbelievable. And since Weiss's day, there's been just over half a century, well over 70 years of research showing the pathways in the bodies, the epigenetic mechanisms, the chromosomal mechanisms, the impact of stress on inflammation, the effect of racism on inflammation, the triggering of oncogenes by stress, and so on and so forth. And in the face of all this evidence, it's still an ignored dynamic in most medical offices. Now, why is that? Well, I don't know about you, but I can tell you that one thing about me, that when I went to medical school, I was a very driven person.
Mm-hmm.
It's not only that, I mean, I had my, you might say, idealistic reasons that you want to serve humanity, and there's no better venue for that than the helping professions, medicine in particular. Naturally, I also wanted the security of employment, but I was curious about the human body and the human soul, all that. But there's something else too. I desperately needed to be important.
Yes.
No.
Yeah.
Now, why did I need to be important? Because of my own infant trauma, where without going into details here, the message I got from the world that I wasn't wanted. Now, if you're not wanted, you're going to be important so that they'll want you for what you can offer them. To that degree, that doesn't take away from the other genuine motivations for becoming a physician. But when that's the driving force, or say driving force, you're going to put yourself through hell to become a physician. And medical school for a lot of people is very hellish. It's very traumatizing. It's very challenging. It's wears body and soul. I don't have to prove that to this audience or to you. Who would put up with that? Somebody who's very driven. And and then we go into practice, not having dealt with our own traumas, not having heard a thing about this stuff in all our education. The average physician doesn't get a single lecture on trauma and its relationship to illness. Not a single lecture, despite all the evidence. Then we go out there and practice with half our brains tied behind our back because we don't understand our patients. We only see their behaviors and their symptoms. And we might understand the biology of their illness, but we don't understand the biopsychosocial nature of their illness. And then we're supposed to practice, and particularly in systems that are designed very often for profit and control rather than the benefit of practitioner or patient, where you get this perfect storm. And then you have a immense stress like the COVID pandemic. And nobody in medical school ever taught you to look after yourself. You know, in fact, we're supposed to even deny that we have any problems at all. Um, in the book, I quote my friend Lissa Rankin, who used to be a OBGYN.
Mm-hmm.
She was training in her residency. In one of her books, The Anatomy of a Profession, she describes how one night 4 babies died on her watch. She wasn't allowed to cry about it in the doctor's room. She was told to get out there and keep working. Jeff Rediger, the Harvard psychiatrist to whom I just referred, who wrote a book on so-called spontaneous remission, which is not spontaneous at all when you actually study it, which he did. But when he was a resident, he had a young child born, his own child who had to be in infant ICU. He wasn't given a day off to visit the child. This is how we're trained.
I mean, I see a lot of myself in the stories that you've outlined and the path that I've taken in healthcare. I think one venture that I would offer as to why our healing industry has been unable to respect this whole body of knowledge that you so eloquently outlined in the book, and one that I think might be relevant for me in particular, is this desire not only to be important but to be effective. Yeah. So the counter narrative that some people might say to what you've offered is, this is all well and good, but I want to be effective. I want to actually help people, but I can't fix poverty in my clinic. I can't intervene on these social macroscopic forces that, granted, have a causal role in these disease processes. But when someone's in my clinic and they've got cirrhosis, like, look, we got to get them on Lasix. We have to put them on, all these other medications. And we can have that conversation later about, what traumatic forces led them to, these manifestations. So I think a lot of physicians went into science, a science-based industry in particular, because they wanted the tools of technology to be able to actually move the needle on their patient's health in a way that other industries, with all due respect, can't quite replicate. how would you respond to someone who's like, I hear what you're saying and I fully understand mind body unity, but what do I practically do in a clinic setting to use that knowledge to help someone?
Well, first of all, it's a very fair question, and there's no doubt that in the acute medical crisis setting, you just want to give that Lasix and balance the electrolytes and get rid of the ascites and whatever else you need to do. That's not a time to sit down and talk about psychosocial issues. But even there, awareness of these issues makes a difference. There's no doubt that how we show up as physicians, regardless of our, not regardless of, assuming same level of technological or medical expertise, if I show up as empathetic, understanding, deaf patients didn't really choose to become an alcoholic. Alcoholism represents, not arguably, but documentably, adverse childhood experiences, traumas.
Mm-hmm.
They're drinking to soothe their pain, literally. They didn't choose to become cirrhotic. How I approach them, my tone of voice, my body language, the way I speak with them, the way I listen to them changes. That alone has been shown to have a healing element to it, just the interaction. You haven't talked anything about trauma or social illness, but just how you approach the patient, how you show up as a human being makes such a huge difference to their experience. That's been shown as well. Number one. Number two, yeah, well, you deal with the acute situation. But if there's a follow up, then you can certainly say, no, look, can we talk about why you drink? Uh, what happened to you? What pain are you? Because I'm telling you, again, it's one of my other books, In the Realm from Repose on Addiction,
Mm-hmm.
documents and shows that addictions of all kinds, whether to substances or alcohol or pornography, whatever, they're always attempts to escape some internal distress, some trauma imprint. So my mantra here is, I talk about it in this book as well on the chapters on addiction. My mantra is not why the addiction, but why the pain.
Mm-hmm.
You may not, as a liver specialist, hepatologist, have the counseling skills or even patience or time. But at least if you're aware of that dimension, then you say to the patient, now look, having dealt with the acute issue, can we look at the larger circumstances that drive this behavior on your part? Are you willing to talk to somebody? Because I'm telling you, it's not your fault. And you never chose it consciously. It's a result of deep trauma. And we can, now, dealing with that will help people deal with the physical illness.
Mm-hmm.
And if I can give you, I could show you, I could share with you on my screen a photograph of a young woman taken 5 years ago in London, England, where I gave a talk. Fingers white with Raynaud's, almost as white as your sweater, and the typical butterfly rash of lupus. And that was 5 years ago. And I can show the photograph today. Rash is gone. Fingers are suffused with blood, pink as anything. No medications. She was told that for the rest of life she'd have to be on medications for lupus. You know what she did? She dealt with her childhood trauma, dealt with how she was stressing herself unwittingly as a result of those traumatic imprints. The disease is gone. I know umpteen examples of that. Other people have documented it as well. So when we talk about wanting to help people, I'm interested in helping people as well. So yeah, when somebody first comes in with their lupus or their rheumatoid or whatever autoimmune condition, you want to help them with the physical symptoms, not give them a lecture on psychosocial medicine. But at some point, very early in the game, and I'm telling you, most people are not only open to it, they're grateful for it, and it can make a significant difference in the trajectory of their illness. And I know physicians who practice that way, and they affirm this as well as I do, including I know a rheumatologist in California who read one of my previous books and told me that totally changed her practice, and she's getting much better results with less medication in her rheumatology patients. But she said, don't use my name in your book, because my colleagues will disdain me for practicing them.
Oh, wow. Well, let's get into that because I think most of my patients, when I have this discussion, and the social history section of the initial interview are open to it. But I would say that there's not a small minority of patients that they actually resist it. When I even broached the concept that there might be some stress involved with their irritable bowel syndrome or something else, some of them have actually gotten offended. They actually want a purely medical diagnosis, and I'm kind of surprised at the pushback. What is that phenomenon?
Well, so first of all, when it comes to the research, there's no doubt that IBS is related to childhood trauma, and the more sexual abuse a woman experiences, the much greater the risk of IBS, and so on and so forth, you know? So there's a scientific fact, um, documented fact. Well, I'd say it's a function of two things, and you might not like one of them, but I'll tell it to you anyway.
Please tell me the hard truth.
One is the patient's own fear of dealing with the emotional issues because it's very painful.
Sure.
It's much easier just to concentrate on some physical symptoms and pathological process, even though in IBS it's not very well understood. Although when you think about it scientifically, what does IBS to do with the vagus nerve? And the vagus nerve, as we know, is hugely affected by emotional influences. In fact, the vagus nerve transmits emotions to the gut. It's that simple, you know. So the spasms or blockages of the gut, the diarrhea or constipation, the pain, they all have to do with the functions of the vagus nerve, which is under huge emotional influence, as the brilliant work of Dr. Stephen Porges has shown, and the work of others. So, but there's that resistance of people to face pain. That's natural. You know? But they also need, this is the part that maybe presumptuous on my part, your degree of skill in how you talk to them, the level of safety that you created for them to listen to you, how you articulate your position. Does it seem like a criticism of theirs, or does it appear to them like a criticism, or does it appear like an invitation? We're not taught to talk to people this way. So you may be saying the right thing in terms of factuality or actuality, but are you saying it in a way that invites the client? Or are you saying it in a way that makes them feel defensive? Now, there are some people that you could be as wise as the Buddha and as loving as Jesus, and they still won't want to hear you because they're too afraid of their own unmetabolized emotional pain. But a lot of people, I find that if you learn how to speak to them, they're remarkably open to this kind of information. And that's been my experience over and over again. I mean, I've had to develop a certain degree of counseling skills just to deal with this issue.
Within a managed care setting as well, I feel like that's the added dimension. I mean, you go at length to the sort of the capitalistic architecture that underlies a lot of the problems that we've been discussing in your book. How does one, as a provider, thread that delicate needle when we can't change that we have only 20 minutes with our providers and we have to be typing on a computer and charting and whatnot? So until the system is dramatically changed, if it does, hopefully it will. In the real world setting right now, when it's a litany of patients and ICD-10 codes and pre-authorizations and insurance oversight and all of that, how does one begin to bring in these issues in such a time compressed fashion, especially when it's not reimbursed? This is really going to have to be on the goodness of the provider to have that discussion. I've learned some tips along the way, but I know a lot of providers are truly, they're lost. They don't really know what to do. And as you pointed out, we don't get trained on this in med school. So it's being a new skill set they have to learn.
Well, I mean, you're throwing me a challenge that I don't think I can rise to.
Right.
But just you mentioned typing on the computer. Yeah. Imagine if during this interview, I wasn't looking at you and I was sort of focused on my keyboard. What would you feel like?
Yeah, we feel so neglected and not heard.
Yeah, and yet, this is increasingly the case. There was an article a few years ago in the New Yorker by Atul Gawande, well-known physician and author, and talking about this dynamic. Look, in the context of a for-profit managed care healthcare system, which fortunately, being up in Canada, I didn't have to function with it. And although, believe me, towards the end of my practice, it got more and more bureaucratic.
Right.
More and more paperwork, more and more forms, and so on. And I was actually part of the reason eventually, well, beside the fact that other things to do. But one of the things that instigated my retirement was I was just tired of that. You know, I don't know what the answer is to that question. I think there needs to be powerful, organized, coordinated resistance on the part of physicians. There needs to be like, you know, we need to man the or not man, man and woman and all genders, the barricades here, because inside that system, I think it's very difficult. Now, I do think that even inside the system, the more human contact you can provide your clients, the more satisfying it is for them and certainly for you. But it must be intensely frustrating. And I don't really have a good answer.
Well, I mean, I feel like that's kind of what we've come to in healthcare. I mean, a personal mission of mine is to help heal the healers, and
Yeah.
I've written extensively about healthcare burnout, and I think, as your book sort of has also pointed out, it's really moral distress. It's moral injury. I mean, the people that go into our industry, you know, I strongly still believe are truly motivated primarily to help others. And so this fundamental systemic frustration, whereas you pointed out, the system itself is dramatically impeding and acting as an obstacle to those primary motivations to have that human contact, ends up causing dramatic burnout. And I wanted to quote actually a Twitter post by an ICU nurse, his partner, during the height of the COVID pandemic, to see what your thoughts are. She wrote, "Every single one of his patients is dying. It is crushing his morale. He is a healer and he can't help them. He can't save anyone. By the time any patient reaches his COVID unit, they have no chance." And then she goes on at length to describe how, as the partner to this ICU nurse, she herself now has a secondary caregiver stress because she doesn't know how to care for him in this moral sort of quicksand that he's found himself in. And I know a lot of providers that are dealing with the detritus and the residue of this phenomenon. And this is what I call this is the other long COVID, not just what's happening to patients, but with the providers that doesn't get as much attention. So for those who are listening, who are inspired by your work and want to take the first step towards healing and understanding that what they're going through is also a process, what might they do as that first part of their own healing journey to kind of get right again?
Well, boy, that's a rich question. Rich in possibilities. When I worked in palliative care, I knew all my patients were going to die.
Mhm.
There were GPs whose patients were admitted to the ward who never visit their patients once they're admitted to palliative care. I suspect because they couldn't face the idea of the false idea, but nevertheless the assumed idea of their own failure. They couldn't save this life.
Yeah.
So the first thing that leaps out at me is this person in the nurse. They're confusing healing with curing. So even if people are dying, you can still play a healing role in the trajectory. And that's totally clear in palliative care. But in a certain sense, many of the COVID cases were palliative care as well.
Mm-hmm.
That doesn't mean you don't try to do your best, but you don't. When I outline in this book, The Myth of Normal, the characteristics of the disease-prone personality, these are personality traits that conduce to illness. One of them is a rigid identification with duty, role, and responsibility rather than self. So if I identify myself as this doctor who has to save everybody, then when that fails, as inevitably it does, then I'm a failure. There's something wrong with me. And I recall the tragic case of I think he was an emergency physician in New York who committed suicide.
Yes. Yes.
And her case was broadly written up. And I thought, well, this poor colleague of ours was over-identified with her role. It wasn't just that people were dying. Yes, that's tragic. But if my role is somehow to be God and prevent them from dying, then it crushes me that I failed in my role. So there's an over-identification. Now, in the Bhagavad Gita, which is one of the great Hindu classics,
Yes.
there's this phrase that says, You're entitled to your work, but not to the results of your work.
Exactly. Yes.
Now, so we're too, in this society, not just physicians, but people in general, are way to identify with their roles and the outcomes of those roles. That doesn't mean we don't do our best, but it means that doing our best is the goal.
Yeah.
And once we've done that, we let go of the result. That may seem like a difficult concept, but certainly in palliative care, that was the case. And in a certain sense, when I was working in the heavily addicted population, I was a failure because many of my patients died of overdoses or suicides or hepatitis or endocarditis or abscesses in their brains,
Mhm.
HIV, and so on. Well, but you know what? I did my best to help them, to heal them in the best sense of the word. And healing doesn't always mean cure, but it does mean that I can be a healing presence in their lives. And that's what we need to strive, is to be healing presences. Outcome may not be in our hands. So that's what comes up for me is this. No, we need to disidentify from our role. And we're human beings performing a service, providing necessary care, but that's not who we are. And so the success, quote unquote, of our work cannot affect or should not affect how we feel about us as human beings. And that takes work. It takes work to disidentify like that. It really does take work because our society rewards us for the role. I mean, so when I was a workaholic doctor, ignoring my own kids for the sake of helping everybody else, the world thought I was wonderful, always available, always supportive, day or night. And I was grinding myself into a depression and ignoring, not willingly or not consciously, my own children because I was so identified with the role. We have to disidentify.
I had been going through something similar. I mean, I certainly had sort of a martyr complex when I entered medicine, and I had this sort of role collapse, and I've been going through, my healing journey to kind of reestablish a balance. So this might be a bit of a broader question, but I mean, a lot of the book, the sort of the meta discussion is about being open to essential truths that we as individuals in our societies have lost contact with, and therefore have lost that authenticity and the ability to form attachments. So how do you do what you have done, where you have lost, unfortunately, patients to all kinds of tragic illnesses, despite your healing presence? How do you remain as a person and as a healer open to the possibilities of the future and of healing and maybe of curing when you have had such a litany of very painful losses when people and your patients go? And I know that the sort of the habitual closed off doctor that doesn't listen, I mean, that itself is a reaction to pain and not wanting to have to deal with failure. The GP that is not visiting the patient, that's the emotional callus that is developed, because how else do you survive in a system to be this open to all these wonderful sort of concepts would be emotionally crushing for a lot of people. So how do you balance the need to be resilient in an emotionally difficult culture? You use that culture metaphor at the beginning of the book, versus not being so closed off to the presence and the human needs that are at the heart of what we're trying to do.
Yes, well, I'd be doing myself a disservice if I said that these quote unquote failures are the only outcomes I've ever achieved.
No, I'm not trying to imply that. So yeah.
No, but what I'm saying is that is a part and parcel of a very broad range of experiences. Where
Yeah.
even in palliative care, when people were dying, they'd be having healing experiences. And strangely enough, I know this is hard to hear and maybe difficult to understand, but some patients said to me, Doc, this disease that's taken my life is the best thing that ever happened to me. And what they were talking about is that the illness forced them to confront their own lives for the first time, to look at the dynamics and to understand themselves and to accept themselves. And that was worth it to them. Now, I don't wish that on anybody.
Mhm.
I'm just saying that even in the context of dying, you can see some beautiful healing experiences. And then I've seen a lot of people who were able to take on their addictions or their chronic autoimmune conditions or whatever, and actually learn from them and transform their lives. So now, if I wasn't open to the so-called failures, I also wouldn't be open to the success. So part and parcel of the same broad dynamic of what we've called here biopsychosocial
Right.
medicine. Once you open that door, you're going to have some beautiful successes and you're going to have some so-called failures, which are not failures at all. They're not your failures. And you still have made a huge difference to somebody's life. So for me, there's no contradiction there.
I mean, I love that answer is being open to the moments that I think our current healthcare model has ignored to find moments that can provide solace for providers. So in the last kind of, 10 minutes of the interview, I wanted to kind of shift to sort of a larger lens here. One person actually wrote, and I'm curious to see if you agree or disagree with this sentence: all Western chronic diseases are diseases of excess. Is that true or not true, and how so?
By excess, like too much eating, too much drinking. Is that what I mean?
Or in some cases, he was also referencing to overthinking, dopamine addictions, all kinds of excess,
Well, there's something in me that resists that phrasing for all the truth that it contains. Because if you take, for example, the adverse childhood experiences studies, the ACE studies, which showed that the more adversity an individual has to endure in childhood, the greater the risk of autoimmune disease, the greater the risk of addictions, and so on. So you might say that the hepatitis is a result of excessive drinking. But why was that person drinking excessively? As I said earlier, to run away from the pain that was inflicted on them in childhood. So to say or say the epidemic of diabetes, people are eating junk foods and too much junk food. So you have this epidemic of obesity that's besetting the globalized world from Canada to China, United States, Mexico, everywhere. But why? Well, that happens in a context. First of all, the ACE studies began at an eating disorders clinic and an obesity clinic, where people would lose weight with this rigorous program, then would gain it back again until the doctors in San Diego, Dr. Vince Felitti, said, "What's going on here?" They said, "Don't you realize?" The patient said, "We're stuffing down our pain." So why are people overeating? Because they're stressed. The junk foods activate endorphin release in the brains, which make people feel better. The junk food companies precisely target those circuits. I mean, that's been documented. It's not a conspiracy theory, it's a conspiracy reality. Read that book, Sugar, Salt, and Fat.
Yeah, yeah.
Why are people eating too much? Because they're stressed. Why are they stressed? Because the economy is in trouble, because there's uncertainty, there's isolation, there's loneliness. So that's why people are engaged in excessive behaviors. So we call them diseases of excess. So diabetes then, the epidemic of diabetes, which has become a worldwide phenomenon. You might call that a disease of excess, but what is driving the excess? Isolation, loneliness, stress, uncertainty, social, psychological dynamics. So that's a very narrow way to put it. For the accuracy it may contain, it's decontextualized. That excess happens in the context of a globalized system that encourages the excess and literally profits off it.
I feel like it may be partially accurate, but insufficient.
Sure.
I think the last question I'll end with is kind of what was running through my mind the entire time I was reading this wonderful book, which is rupture and repair. I think all relationships involve a balance of the two, and hopefully more repair or an equivalent amount of repair as there is rupture. The relationship we have with ourselves, the relationship we have with our fellow citizens and family members, our patients in the context of this discussion. And I look at least America right now, certainly through the lens of the healthcare system, but just writ broadly, that we are a society in despair. We have the deaths of despair. Angus Deaton at Princeton has commented on that, as I'm sure you're quite well familiar with. And the one thing that comes to mind is that we are in a period of rupture. We all feel it, I think, regardless of political views. We may disagree on why, but that I think is something that unites all of us. And I don't think a repair movement has, despite the efforts of very well-intentioned and effective people, has been able to counterbalance all these large forces pushing rupture. So how do we reestablish that balance? How do people repair their connection with themselves, which may be the first point that they can work on, is that authenticity with themselves?
Yeah.
And how does that translate into society? And you do outline some kind of key ideas at the end of the book, which I loved. And I was curious if you could maybe provide a bit of guidance for our listeners.
Well, Dr. Ed Tronick, who has just recently published a book on rupture and repair. You might want to look at it.
Yeah.
It's a huge issue, and Dr. Dan Siegel of UCLA talks about integration, and what the society lacks is genuine integration, and individuals lack integration in themselves. So, and as Dan Siegel points out, when there's threat, the tendency is to identify with group and identity and see others as enemies. So when you put a society under stress, such as globalization has done economically, the hollowing out of the industrial heartland, these deaths of despair that Deaton talks about, when politicians deliberately exacerbate the flames of racial and cultural differences and hostilities. When people are scared, then they tend to go into defensive, hostile mode, and the possibility of social integration in a genuine sense diminishes. That's often tied to individual psychology. Interesting studies have been done, for example, on extremist personalities, right-wing personalities, and basically they're fear-based. Their amygdala tends to be larger on brain scans, at least on one brain scan study that I saw. That has to do with childhood development and trauma. So the integration has to begin, well, I don't know where it has to begin. I can't prescribe for society, but at the individual level, it needs to begin by looking at ourselves. That real desire to where did I get disconnected from myself? Because somewhere in our upbringing, most of us get significantly disconnected from ourselves. We identify with external values and evaluation, external goals, external rewards, and we forget who we actually are. We don't even know what we feel anymore. So that's the impact of trauma and that reconnection with ourselves. The word health comes from the Anglo-Saxon word for wholeness. And so that striving to become whole, that reconnection, at least for me, it needed to begin on the individual personal level, which doesn't mean that one forgets about the larger factors, but the more I'm integrated in myself, the more articulately and I think effectively I can speak to the larger issues as well.
I love that answer, the hero's journey. We all have dragons to slay inside. This has been a wonderful, awe-inspiring interview. Thank you for your time, Dr. Maté. The book is The Myth of Normal, probably the best treatise I've read in the popular press on trauma ever. And I can't recommend this highly enough. This has been a fantastic interview, another episode of the Alchemy of Politics.